Hello, welcome. Thank you for joining us today. My name is Olivier Tournière. I am Motiva VP of Sales for Africa, Middle East, Asia Pacific regions. On behalf of Establishment Labs, I would like to formally welcome you to our webinar. Today, as speakers, we have a group of very famous Brazilian plastic surgeons who will share their experience and knowledge about BIA-ALCL. Learning about BIA-ALCL from Brazilian surgeons is a great opportunity, as in Brazil, they have been using all kinds of textured surfaces, from macro textured to polyurethane implants. In Latin America, as in the majority of the region of the world, BIA-ALCL cases have been underreported. You will be able to learn and ask questions so you can best cope with this disease if you are ever confronted to it. Okay. It is now 8 a.m. in Sao Paulo, 1 p.m. in Paris, 6 p.m. in Bangkok, 9 p.m. in Sydney. It is great to have the opportunity to sponsor this training and to put together plastic surgeons coming from different horizons. Without further delay, I would like to virtually pass the microphone to Dr. Ruth Graf, who will be our moderator today. Dr. Ruth Graf from Curitiba, professor at the University of Paraná. Dr. Graf is very famous. She has developed the subfascia breast augmentation technique. Dr. Graf.
Okay, thank you very much. Thank you very much for inviting me to participate in this webinar. ALCL is a very important issue that every plastic surgeon has to know about everything about that. So it's a good opportunity to learn more. It's my pleasure to moderate this webinar. And I would like to introduce Dr. Alexandre Munhoz. He is from São Paulo. He's a professor at the Medical University in São Paulo. And he is going to present the update of 2020, the epidemiology and the risk factors of ALCL. Dr. Munhoz, please.
Hello, everyone. I'd like to thank you for the invitation to participate in this Motiva Ed webinar. This is my disclosure with Established Labs and Motiva as advisory board member. My name is Alexandre Munhoz. I'm from São Paulo, Brazil, and today we're going to talk about ALCL, an update in 2020, especially related to epidemiology and risk factors. And in relation to aspects of the implant surface, we published last year together with Mark Lemons and Maurice Nahabedian an update on the physical characteristics of the implant surface available on the market and the influence on the evolution of the capsule stability and complications. And here it is important to classify the different surface, the definition of macro texture and smooth, and the behavior of each one in the formation of the capsule and impact on reoperation. Among the main ones, the ISO classification used by more than 40 regulatory agencies, and the Jones et al. Classifications, both of which classify according to the roughness. The Jones classification is interesting because in addition to the roughness, it also uses the surface area and the production method. In this talk, I will use this classification to define a smooth, micro, and macro texture. Here we can see an example of a grade 3 and grade 4 surface in our reoperation cases, which its details of tissue adhesion into the capsule. And before you define ELCL, you need some concepts, especially related to lymphoma. Lymphoma is a neoplasm from immune system, lymphocytes, and is the most frequent hematologic cancer, like Hodgkin, non-Hodgkin myeloma. In 1985, Stein defined it as a subtype of non-Hodgkin lymphoma, the ELCL, and it represents almost 2 to 3% of all non-Hodgkin lymphomas, and is defined as a giant cells anaplastic with expression of CD30. And it's totally different from breast lymphoma, which it is a hard breast cancer, which is not 90% origin in B lymphocyte and affect the breast parenchyma. In 1988, World Health Organization recognized it as a subtype of non-Hodgkin lymphoma, the ELCL, as a disease with heterogeneous and clinical presentation and outcome. It presents a benign form as a lymphomatoid papulosis, a cutaneous 90% survival in 5 years, and a 2 to 3% systemic form with aggressive, and the diagnosis is with metastasis. And in the 90s, the association with breast implants. 1997, Stein and Leonard, the first case in an implant in the capsule. 2008, Jong, the first association with textures. And 2014, the first case series. 173 cases, 170 exclusively in the capsule. And what factors are related to the current incidence and the risk of ELCL in patients with silicone implants? And for these aspects, we have some important points. Number one, assessment risk for ELCL is inaccurate and variable in different countries and regions. Number two, multiple variables and infrequent occurrence make the analysis of epidemiological studies something complex. And number three, the risk estimation depends on precise measurements of the prevalence of patients with implants and the number of cases in a given population, the concepts of numerator and denominator. And numerator and denominator are very important in the ELCL calculation. Here you have the numerator, the number of cases of ELCL. Clinical presentation and poor registers are directly related to the number of the cases, as well as patient specifics like ethnicity, genetics, cultural, and socioeconomics. These numbers are very variable. And the denominator, which represent the number of patients with implants. The denominator is very variable because it depends on the numbers that are provided by the industry, which is not regulated to yield the numbers, and the wide range of implants on the market, different manufacturing methods, different materials, surface types and grade, and surface area. And what does the literature show in relation to the incidence of ELCL? And what is the comparative relevance for our practice? And here you have a visual idea comparative to our reality. I use a football stadium full of fans. I use here the Barcelona stadium, the Camp Nou, because it has an approximate capacity of 100,000 fans. Each area of this stadium represents almost 350 fans. If you take a look to the Broad's paper published in 2015, the incidence of ELCL is 1 patient for 3 million persons with breast implants. It represents 1 woman in 30 stadiums full of fans. And in 2017, Doring reported 1 case to 500,000 patients, which represent 1 woman in 5 stadiums full of fans. And Locke Wilson from Australia published in 2017, different surface you have different risk. One for 2,800 for grade 4 textures. It represents 35 patients in a stadium full of women. 1 to 3,800 for grade 3 surface. It represents 26 patients in a stadium. And 1 to 6,000 for grade 2 microtexture, which represents 1 patient plus health patient in a stadium full of women. And Mark Guyer in 2017, based on the CARE trial of grade 3 surface, it was one of the post-approval studies by the FDA, a prospective level 2 evidence, showed 4 cases in 17,600, which is equal to 1 for 4,400. And in 2019, an update, there were more 4 cases, which represent 8 cases in 17,600, which is equal to 1 for 2,207, and represent almost 45 patients in a stadium full of patients with breast implants. And Cordero in 2020, in a cancer patient series submitted to reconstructive surgery with grade 4 textures, showed 10 cases in 3,546 patients, which represent 1 case each 354, or 282 patients in a stadium full of fans. This is the largest series of ALCL from a single surgeon worldwide, and represent a reconstructive cohort. In this way, you went from a very hard situation, the study of Brody in 2015, to an infrequent situation, the work by Cordero in patients diagnosed with breast cancer, published in 2020. And we think, if you have a large population of women submitted to exposure to an agent, the silicone implant, and only 1 in 350, the Cordero study, develops the disease, this leads to the belief that there are other factors than just the silicone. So we have the theories, the chronic inflammation, the infection, the genetics, and the time. So let's start with the inflammatory theory. It is well recognized the relationship between the chronic inflammation, the hyperactivation of the immune system, and the higher risk of cancer. If you take a look to rheumatoid arthritis, the patients has more incidence of melanoma, lung, and renal carcinoma. And lupus erythematosus, the patient has more risk of non-Hodgkin lymphoma, gynecological cancer, kidney, and hepatocellular carcinoma. So chronic inflammation is related to the higher risk of cancer. And what is the relationship between the lymphoma, alloplastic materials, and chronic inflammation? One interesting study published by the Rush University in Chicago group evaluated the debris from orthopedic implant as well as the breast implants, and observed that the debris induce a bioreactivity and inflammation. They activate immune cells like macrophages, cytokines, TNF, and interleukins. If you take a look here in the histological section of rib replacement, you can see a smaller sizes of submicron debris. Even in the metal on metal rib and metal on polymer, which present larger debris that is more elongated in shape. The same aspect as is observed in a peri-breast implant tissue, where you can find large implant particles encapsulated by macrophages and surrounding by lymphocytes. It's an ALCL case in a breast implant. Based in years of experience with orthopedics implants, The authors concluded that increased implant debris will result in increased pathogenic inflammation over time. Conversely, less particulate debris will result in less inflammation and improve the performance of these implants. In addition, the authors discussed that a subset of patients susceptible to ALCL will be more vulnerable to implant debris than the general population. And utilizing implants that minimize this response may be the paramount in these patients in order to avoid the ELCL problem. And the group from Mayo Clinic evaluated the number of debris in different implants, texturized, grade 2 and 3, FDA approved, through the scanning electronic microscopy. The authors utilized a liquid adhesive, it's EVA, that was applied to the external shelf of the implants, allowed to peel it from the surface and calculate the number of the debris in this different surface. The authors observed that the peeled copolymer exhibited surface shedding. Comparison of the 3 breast implants showed the shedding to be greatest for the grade 4 implant. Here you can see the different surface. The control group is smooth. No debris can be seen on the sections. The grade 4 surface, white flecks indicate shedded particles of silicone from the surface. And grade 3 surface, little surface debris was adherent to the EVA copolymer. And other studies show that not only is the capsular fibrosis a simple foreign body reaction, but silicone itself, the degradation products of silicone, and especially the silicone debris, combined may trigger a special local immune response of lymphocytes. In fact, the group from Austria evaluated the immune response activation and the function characterization of different lymphocyte phenotypes in the capsule versus in the blood. The authors observed that silicone implants trigger a specific local immune response and not just a foreign body reaction through the activated Th1 and Th17 cells, suggesting that ensuing fibrosis is promoted by the production of cytokines as a consequence of faltering function of local T-regulatory cells. Moreover, the ratios of intracapsular T-regulatory cells were inversely proportional to the clinical degree of capsule fibrosis, Baker 1 and 2 versus 3 and 4. And the same group from Austria evaluated the activation mechanism of the lymphocytes and the different cytokines produced according to the surface of the implant. For this objective, they collected peripheral blood from female donors and used 16 millimeter samples from 7 different implant brands. And they did cell isolation and in vitro culture and flow cytometry analysis. And through immunoassay, they evaluated different cytokines like TNF and TGF-beta and interleukin 1 and 2. And based on this methodology, the authors concluded that silicone surface do not induce T-cell proliferation and even the proportion of T-cell subsets. However, the most important that the pro-inflammatory cytokines were different depending on the surface analyzed. CD68 was significantly reduced on silk surface. There were a downregulation of TNF-alpha on silk, velvet, and micropolyurethane foam. In addition, interleukin-10 was downregulated on all surface except Polytech and Siltex, and a moderate but not significant upregulation of TGF-beta-1 on all surface except on silk surface. And it is interesting that TGF has both anti-inflammatory and pro-fibrotic properties. It is well known that increased production of TGF-beta in tissues induce local fibrinogenesis. Moreover, silk, velvet, and micropolyurethane show at a lower degree of inflammation based on the downregulation of TNF-alpha and interleukin-1 beta levels. And the infectious theory. And one important paper published by the group from Montana State University evaluate the bacterial adhesion and biofilm formation on texture breast implant shell materials and compare it to a smooth and smooth silk surface. The authors inoculated 3 types of bacteria, Staphylococcus propionibacterium and Haustiana piquetti, in a CDC reactor, which evaluate the formation of biofilm and evaluate in terms of numbers in 6 and 24 hours. In addition, surface metrology results for the breast implant surfaces were evaluated in this study. The 2 least Huff surface, silk and velvet, have similar surface areas as did the 2 must Huff surface, Siltex and BioCell. Concerning the biofilm formation and the different type of surface, the authors observed significant difference in terms of the 2 hours and 24 hours in biofilm. If you take a look in this graph, in 2 hours, Siltex surface presented more biofilm than the silk surface. And in 24 hours, biofilm surface presented more biofilm formation than velvet and silk. And Siltex surface presented more biofilm than velvet and silk surface with significant difference. And why the surface area and roughness has an influence on bacterial adhesion and biofilm formation. Basically, we have some surfaces that have a lower surface area and others that have a higher surface area. It is well known that higher surface area, the area of contact and interaction with inflammatory cells and bacteria are higher. Thus, the higher surface area, HSA, acts as a platform to provide adhesion and proliferation of the bacteria, and in a more intensity than a lower surface area. And surface area is an important issue. If you take a look and compare the difference of surface area between grade 4, grade 3, and grade 2 surface implants, you can see how big it is in terms of the dimension of the surface area. If you compare it with the risk of ALCL, you can perceive a direct relationship. It is almost 16 times more for grade 3, 23.4 higher with grade 4 when compared to grade 2 implants. And finally, the association between the infection and the inflammation. And this subject was well studied by the group from Australia, where they evaluated the chronic biofilm infection and the stimulation of T cells. They used a pig model where they implanted textured and smooth implants for a mean period of 8 months, and a human model where they extracted 57 capsules from patients with Baker 4 cap cone and analyzed the biofilm, lymphocyte, by culture and nucleic acids. The authors observed a direct relationship between the Baker skull and the number of bacteria. If you take a look in this graph, Baker 4 cap cone has more bacteria than the Baker 1. In addition, texture implants had a significantly higher number of B and T cells on surface when compared with smooth. If you take a look in this table, you can see the difference among the number of CD3 and CD4 T cells between the texture and smooth implants. And finally, there were significantly more T cells, CD4 and CD8, compared with B cells. The number of lymphocytes correlated with the number of bacteria per milligram of capsule tissue. And the most important, the difference of the number of T cells when you have a biofilm in a smooth implant and a texture implant. Biofilm infected texture surface had almost 63-fold increase in the number of T cells compared with biofilm infected smooth implants. And in summary, implants with higher toughness and surface area may present an increased implant debris. The debris can result in increased pathogenic inflammation over time and can trigger a specific local immune response via activated Th1 and Th17 cells. In addition, this surface can provide a better bacterial growth platform and favors to bacterial adhesion and biofilm formation. And finally, in the presence of biofilm, it acts as a stimulator in the T cells activation. And imagine if you have a surface with a higher toughness and with all this aspect and included it in a susceptible patient, genetics, race, and for a long period of time, 8 to 10 years. Maybe you have a favorable scenario to ALCL much more than a surface with a low toughness. And how all this concept will influence ALCL risk and change my surgical practice. Just take a look to the statistics of the disease. More than 600 cases were confirmed worldwide in different countries, and all cases described have a history of texture implant and significant higher for grade 3 and 4 surface. In fact, higher surface area with higher toughness implants has almost a 63-fold increase in the number of T cells and carry the highest risk of BR-ALCL. Second, more than 30 ALCL cases were described with smooth implants. However, no proved cases with only smooth, no history of texture in any published series with accurate clinical history. In fact, up to March of 2020, no pure smooth grade 1 implant described with ALCL. And finally, 85% were related to higher surface area. A recent update, the risk is 16 times higher for grade 3 and 23.4 times higher with grade 4 when you compare to grade 2 implant. In fact, and based on current evidence, grade 1 implant present the lowest possible risk for ALCL. In theory, only smooth risk 0. Thank you for your time and attention, and I appreciate the kind invitation to participate in this webinar. Thank you.
Thank you very much, Dr. Munoz. It's a pleasure for us to learn with you. And now I'm going to present Dr. Anne Groth. She is a professor at Positivo Medical School University in Curitiba, in my city. And also she works a lot in ALCL local society and also in the national society. So she's going to present the BIA ALCL, the regional case in Brazil. Go ahead, Dr. Groth.
Anne Groth. I'm a plastic surgeon in Brazil, and I would like to thank Motiva for promoting medical and surgical education worldwide and also for inviting me to join Motiva webinar in the APAC region to talk about breast implant-associated anaplastic large cell lymphoma, regional cases in Brazil. I have no disclosures. Why this matter is so relevant? Because breast augmentation is the most common aesthetic procedure performed in the world. And also, implants have a major role in breast reconstruction. We estimate that around 35 million of women have breast implants. The first time BIALCL was reported was in 1995. And since then, the FDA has been registering cases, and in the last report was last July, when it reported 573 cases and 33 deaths. And what's the risk to develop BIALCL? Dr. Magnuson from Australia reported last year a paper assessing risk related to texture. And according to his paper, the polyurethane texture has a risk of 1 to 2,800, BioCell 1 to 3,300, and Siltex 1 to 86,000. Recently, Dr. Peter Cordero from Memorial Sloan Kettering in New York showed an even higher risk in a series of reconstructive cases using BioCell, a risk of 1 to 355. When should we suspect of BIALCL? Seroma is the most common symptom. It occurs in 60 to 9% of patients, usually 8 to 9 years after implantation of textured implants. Other presentations can occur like mass, capsular contracture, rash, and lymphadenopathy. But are all late seroma BIALCL? No. Only around 10% of investigated seromas turn out to be BIALCL. But all plastic surgeons will at some point evaluate a patient with late seroma, and today it is mandatory to rule out BIALCL, especially in patients that have been implanted with aggressive textures like Jones 3 or Jones 4. Brazil is probably the largest breast implant textured market in the world. We have a population of 210 million, 27 states, and Paraná is one of its states. It accounts for 5% of Brazil population, 11 million people. It's located in the south of Brazil, and you probably heard about us due to Iguaçu Falls. What have we done here in Paraná? We promoted locally a series of workshops, meetings, and lectures with other medical specialties like radiology, pathology, clinical oncology, hematology, and plastic surgeons. And based on NCCN, we developed local algorithms. And also, we looked for diagnostic problems. We also advised and support for suspected cases of BIALCL. The most common problem for diagnostic problems were sample problems. Or the seroma sent to lab was not enough, or it was sent in some kind of preservation medium, or it was evaluated long after 12 to 24 hours. We have to think that this analysis is a fresco analysis, so it's time sensitive. Anything that can lead to cell death will impair our ability to diagnose properly. What we've done here, before, if we have a suspicious case, we communicate with the radiologist, hematologist, and pathologist, and the first step is to schedule the ultrasound-guided aspiration. Then the radiologist takes 2 syringes. The first syringes, around 20 cc's, it's sent to the pathology lab for a fresco analysis, and it should be refrigerated for transported. If the analysis cannot be done immediately, you should contact the lab to see if there's any kind of preservation medium allowed. The second syringe goes to the hematology lab for flow cytometry. Also, a syringe of 20 cc, it will be done on a fresco analysis. It should be as well refrigerated for transport. And here, if the sample will not arrive in 6 to 12 hours, you should contact the lab to see if they will accept the specimen for analysis. Also, in the exam requisition, be sure to inform that it's a BIALCL patient, suspected patient, so that markers like CD30 and ALK will be performed in these samples. Other problems observed here is that flow cytometry facilities are located in large centers. In Paraná, they are located only in Curitiba, which is the capital. So in many cases, the diagnosis is only by cytopathology. So it's paramount that the pathologists have a high degree of awareness of this disease and perform immunocytochemistry as a routine. So far, we have reported 13 cases of BIALCL in Paraná, both aesthetic and reconstructive. The most common symptom is seroma, and the most common texture is polyurethane, followed by biocell and urosilicon. I will show you some aspects of some of these cases. The first case reported was a breast reconstruction patient with a biocell implant that developed a mass 3 years after implantation. It was an advanced case that required systemic therapy with chemotherapy. The second case is also a breast reconstruction with biocell, 6 years, showing only seroma. And it was staged as 1A, which is a very early stage where the cells are confined only to the seroma. No systemic treatment required here. It is very, very important to confirm or rule out BIALCL before operating a suspected case. In this case, the patient had a polyurethane implant 11 years after implantation, showing a seroma. It was operated without diagnosis, and after surgery, it was diagnosed as BIALCL stage 1B. But it was placed new textured implants during the surgery because it didn't have the proper diagnosis early. And we know that NCCN does not recommend the use of textured implants in patients with BIALCL, only smooth ones. This is the only case in the series that didn't show any seroma. It was only a case of capsular contracture. This case, a polyurethane for aesthetic, 8 years after implantation, showing both seroma and capsular contracture. Here, it's important to open the capsule in the posterior aspect of the capsule and perform a macroscopic evaluation in search for nodules or masses. This patient was staged as a 1C. This other patient, it's a polyurethane for aesthetic, showing only seroma. And here we can see some masses in the inner aspect of the inner aspect of the capsule after macroscopic evaluation. She was staged also as a 1C. I would like to emphasize the en-bloc capsulectomy, the en-bloc resection. It means removal of the implant, the capsule, the surrounding tissue, and the seroma within as one, with not opening the capsule and not spilling the seroma in the surgical field. Like this. This is a case that we can remove the seroma after the en-bloc resection. We see some surrounding tissue, a little bit of fat surrounding the capsule, so you can remove the specimen as one, as an en-bloc resection. In this case, the patient had a urosilicon implant 9 years after with a seroma and was staged as a 1C. However, As the capsulectomy was not done as unblock resection, the clinical oncologist considered that it had residual disease, and the patient, even though was a 1C, was submitted to chemotherapy. We know that in the world, 85% of the cases are diagnosed early, and the surgery alone can lead to cure. And here in Brazil, in Paraná, we have 31% of late stages and advanced stages disease. So what we know so far, BIALCL is uncommon. It is a cancer, but it's not a breast cancer. It usually occurs after 8 to 9 years after implantation, after patients have been exposed to textured implants, and early diagnosis can lead to cure with en-bloc resection only. What we must do? We must detect early through medical education, patient education, and collecting local data of confirmed cases. It's not simple to diagnose BILCL in Brazil. There is a huge amount of notification. If we extrapolate the data from Paraná to Brazil, we should expect at least 250 cases in Brazil. Regional meetings with other medical specialties does increase awareness about the disease, and all plastic surgeons should be aware of this disease and diagnose early, know how to diagnose and treat, and know how to minimize the risk through state-of-the-art techniques.
Thank you, Dr. Anne, about sharing with us your presentation. And I'd like to discuss about the ALCL, and I'd like also to ask for the plastic surgeon who is assisting us to send your questions, and we can discuss and answer the question of the people who are listening us. So I think we know that it's a rare disease, and it's an indolent aspect of the disease, but it's real, and we have to, all plastic surgeons has to know about the disease. And as we saw, Dr. Munoz told that the chronic inflammation is a topic, and the infection also is the base of this disease. And Dr. Munoz, could you resume for us exactly what do you think about the infections, the inflammations, the local population, and this indolent disease for us, please?
Yeah, it's a very good point. And as we happen with any heart disease or any heart situation, it's very complex and difficult to do a directly association in terms of cause and effect. Even in a more frequent disease like breast cancer, that it's 1,000 more frequent than ALCL, there is no direct association between cause and effect. So we have risk factors and we have theories. We can recognize in the present times that we have a higher risk of patients to have the ALCL disease. If you take a look to all the studies, experimental, in vivo, ex vivo, or clinical series, 85% are related to a situation that you have a surface, a specific kind of surface that produce more inflammation and that are more able to have bacteria adhesion. And if you mix these two situations, these two scenarios in a long period of time and add to this situation a genetic predisposal, maybe you have a perfect storm. So it's what we have been observing in the clinical series. As I mentioned in my talk, 85% are related to high surface area implants. And there is no pure case of smooth implants. Smooth implants are not a good scenario for a bacteria adhesion. We know this with experimental and clinical studies, and not only in breast implants. We have this in ophthalmology with contact lens, that if you reduce the roughness and the surface area of contact lens, you have less bacteria adhesion and biofilm formation. We have this also in pacemakers. We have this in orthopedic devices and cardiac valve. This is the same, and breast implants are not different. We have the debris theory, and the debris theory is very interesting because if you compare a macro texture to a smooth implant, it is very clear that the macro texture, especially grade 4 and grade 3, produce more debris and produce more particles that will be encapsulated by the capsule and the fibrous tissue. And these particles remains forever, for 10 years, 15 years, 20 years. And you have a situation in a long-term analysis that you have the particle and you have a lot of lymphocytes. And you have a chronic activation of macrophages that stimulate the lymphocyte. And you have a genetic predisposal, so the chance to have a monoclonal proliferation is higher than you compare in a situation that you don't have this particle. This is a part of it.
Thank you, Munoz. And there is some questions from the audience. So, Dr. Groth, there is a question for Croatia. Since when do you have an obligation to report every case of ALCL in Brazil? Since when?
Actually, you don't. Unfortunately, we don't have a national registry yet. We are trying to make it happen. Even here in Paraná, we reported these 13 cases, but I cannot be sure that that's all we have because it's not mandatory. You don't have any obligation, but people talk to me about suspected cases, and we are doing that. But what worked more is that since we got so much in close contact with hematologists and pathologists, they are the one reporting, even more than plastic surgeons. In 2 cases, I had to call the plastic surgeon and try to talk about the case because I knew already we had a case from that doctor. So it is not, unfortunately, it's not a mandatory yet.
Another question for you. What kind of periodic examination of a breast implant patients routinely use ultrasound, if it's enough, or MRI?
That's a great question. NCCN just requires annual ultrasound for screening this disease. So it doesn't change a lot what we do as a routine examination every year. Of course, we have reconstructive patients that usually do MRI every year, but ultrasound is enough to detect, since we know that the most common symptom is seroma.
Okay, and another question that they ask here for both of you is a doubt for all plastic surgeons. Do you recommend the exchange of the implants after 10 years?
Want to go first? Yeah.
We don't have a limit date or a limit year to indicate exchange. I think you have to analyze the context. If you have a symptomatic patient with a good aesthetic result, and if you look to the exams, mammogram, ultrasound, and even MRI, everything it's okay. There is no complaint about some pain or some aesthetic aspects. I think you can postpone and follow up, do the follow up every year, but it's statistical. If you take a look to the 80s and the 90s implants, the great part have some problems in between 8 and 10 years. There are some cohorts of radiologic studies that put all the patients in the MRI at 10 years and 15 years, and you can see almost 30 and 50% of asymptomatic rupture, respectively. So I think you have to discuss with the patients the benefits and the disadvantages, and put an imbalance in order to plan elective replacement. But if everything it's okay in 10 years, one day, and the patient doesn't want, I think you can follow up.
Okay, Dr. Groth?
Yeah, I totally agree with that. The thing is that I tell my patients that they will change their implants around 10 years. But after that, I do exactly as Dr. Munoz said. I evaluate every patient to see how they are doing, if they are happy and the implant is okay. But the patient know beforehand that it has a scheduled surgery around 10 years. So I think that's a very important point, because we see a lot of patients in our private practice saying that they have a lifetime implant. They don't need to change, and I think that's a headache, because it's hard to educate the patient after that. It should be educated when it was implanted. So I think it's very good for us to reinforce that they will have to change implant at some point.
Okay, and another question is, will the texture implants be abandoned to the ALCL?
Wow, that's a tough question. The toughest
Exactly.
question. Yeah. The way I see it now, I think we are in a period of time that we have to educate our patients and the plastic surgeons about this disease, because we are still talking about surgeons not diagnosing and letting patients have advanced diseases. So I think right now, the focus should be education, and should be diagnosing these patients. About choosing the implant, I think you have to know why you use some kind of implant. I think you have to know why you use a smooth or why you use a polyurethane. I think you have to know that, and you have to accept and also be responsible maybe for what's gonna happen after that.
Okay. Another question from Italy, from Elisa Bodletta. I think it's to Dr. Munoz. According to the debated theory about the immune system dysregulations, do you think that pregnancy of breastfeeding could affect the onset of the ALCL?
I don't have this answer, and I think nobody has, because it's an infrequent situation. And if you compare the epidemiological studies, and if you take a look in the retrospect, I think you have some patients with pregnancy and breastfeeding history, but you have a lot of patients with no pregnancy and breastfeeding. I think we have to study more these aspects. It's totally different from breast cancer. It's not breast cancer, and breast cancer has a directly link with pregnancy and breastfeeding. Patients that are nulliparous, that don't have kids, have more chance to have breast cancer, as the same as of breastfeeding history. But we are talking about a different situation. This is a hematological disease. This is a lymphoma, and the risk factors are totally different. Maybe in the next years, with more cases and more epidemiological studies, we can have more conclusive observations about this topic. But up to now, we don't have this answer.
And do you think that patients with autoimmune disease should remove the implant?
It's another important point. We have now the problem of breast islands associated with implants. We have some meta-analysis and systematic reviews in the 90s and 2000 that concluded with a significant power that there is no association between silicone implants and autoimmune disease like rheumatoid arthritis, lupus, sclerodermia. But in the recent years, we have another disease with a very subjective symptoms like Asia syndrome, and some link that on some observations that when the patient remove the implants, the symptoms disappear. I think it's not mandatory to to do the explantation, but you have to discuss this in a multidisciplinary situation with the experts, the rheumatologists, the general clinicians, in order to evaluate the benefits or the disadvantage to maintain or to remove the implants.
Okay. And a question for both of you. Which is your suggestion if the patient has a capsule contracture after 10 years and she has no seroma and the MRI doesn't present any mass, and when you open the patient, open the surgeon, see the capsule is not so smooth and has some small mass that you could not see in the MRI, what do you do during the procedure?
That's a great question, because now we know that a few portion of those patients will present only as capsular contracture. I showed one case here, there was no seroma. And I believe that if you are in the OR, if you're operating this patient and you see a capsule that it's not healthy, and if you can do a total capsulectomy that will not compromise the patient result, I believe you should do that and send it to analysis. However, if it is a submuscular or dual plane implant and you might have any kind of issues removing all the posterior aspect of the capsule, maybe you should just make the biopsy and come back to solve the case if you have a high degree of suspicion for BIALCL.
You don't use a new implant in this patient in the same procedure?
You could, actually you could, as NCCN states, you can use a smooth implant. In this case you could, but remember that if it is proven disease after that, you have to come back and remove the rest of the capsule, so the patient will be treated. Unless, if you don't do that, the patient will have to receive some kind of systemic therapy.
Okay, thank you. And Dr. Munoz, you do the same?
Yeah, I agree with Anya. I think it depends on the case. The first step is to be sure that there is no risk or no evidence of ALCL. And it's just a CAPCOM, and you have to do the replace of the implant. The great part of Baker 4, the aesthetic results are very bad. So in this situation, in the great part, unless you have a submuscular implant, the great part of subglandular implant will remove the Baker 4 in monoblock with the implant. This is the common sense in the great part of the surgeons. But if it is a Baker 2 or a Baker 3, and there is no representation in terms of the clinical aspect outside of the breast, I think you can maintain some parts of the capsule because it's important as a capsular flap, and to make sustentation of the new implant and stabilization of the new implant. Unless the aesthetic result is not good, I think you can maintain some parts of the capsule. This is in a no ALCL situation. In an ALCL, it's totally different, and mandatory the total remove of the capsule.
And the ASAP Society has a task force now. They are studying this patient that has capsule contracture only. So now in this point, we have to finish our webinar. I think all the remaining questions will be addressed offline, so we can continue to work offline. Thank you so much for both of you. It was a wonderful presentation. We could learn a lot. I think it's coming more and more questions here, but we have no time to that. Thank you so much, and thank you for Motiva to join us for these presentations.
Thank you.
Thank you.
Thank you for people who listen us. All right.
Thank you.
Good.
Thank you very much.
Thank you. Foi muito bom. It was
Obrigada,
wonderful.
doutora Ruth.
Yeah. Let's see the next questions. Yeah. I think they are going to send us.
Okay. So
Bye-bye. Thank you, guys. Thank you very much for your time today. It was great.
Yeah, it was very good. Thank you very much for organizing this meeting, and thank you, my friends, my colleagues, Ruth and Annie. And it was very good to share again the talks with you. It was very good.
Yes,
Okay,
the talk was great. Yeah.
Have a good day.
Have a good day.
Thank
and
you.
Good night
Bye
too.
bye.
Yeah.
Yeah.
Nice week.
Bye.